Hello everyone, this is a module organized by the Neocardio Lab. I'm Gabrielle Altit, I'm one of the neonatologists at the Montreal Children's Hospital, and I will be talking to you guys today on the assessment of pulmonary hypertension in the context of neonatal life by using echocardiography. So the plan of the presentation will be to discuss some of the definitions regarding pulmonary hypertension, and then we'll dive into the subject of estimation of pulmonary arterial pressure by echo, the evaluation of RV function, and I will provide you my email if you have any questions regarding this module. Now, this module is really for purposes of teaching and education. And please ensure that you actually validate any kind of information used within this presentation before applying it to your practice. So let's start with the definition. And so, similarly to systemic hypertension, pulmonary hypertension is really what we consider to be an abnormally high pressure in the pulmonary artery. Now, we know that systemic hypertension is based on certain cutoffs, what we consider to be an abnormal high blood pressure in the systemic compartment. The etiologies of systemic hypertension are numerous. So we know that, for example, some patients might have systemic hypertension secondary to renal conditions, cancer, steroid exposure, cocaine use, etc. And it's really by identifying the cause that you can tailor treatment and management. So similarly to this context, if you have high pulmonary pressures in your pulmonary artery, this can be the symptom of an underlying process. So you can think of, for example, bronchopulmonary dysplasia, chronic thromboembolic disease, mitral regurgitation or left-sided heart lesion, persistent pulmonary hypertension of the newborn, or what I prefer to call acute pulmonary hypertension of the newborn, certain congenital heart defects that might expose the pulmonary artery to systemic pressures, are all different causes for having an abnormally high pressure in the pulmonary artery. And it's really by identifying the cause that you can eventually tailor your management. So you can think of a patient, for example, who has a big aortopulmonary window or a big patent ductus arteriosus that will be unrestrictive and that will cause the PA pressure to be very similar to the systemic pressures. But in that specific lesion, if you have, a massive shunt that's causing overflooding of the pulmonary vessels, you will not consider pulmonary vasodilator therapy because this is not the cause of your high pressure in your pulmonary artery. On the contrary, if you have a patient who has severe increase in the pulmonary vascular resistances, such as, for example, in the context of acute pulmonary hypertension of the newborn, then you might consider using pulmonary vasodilation therapy. So this is the classification that was published and modified from the work of Dr. Del Cerro from Spain. And as you can see, within the context of the pediatric population, there are various etiologies, and I'm particularly interested in the newborn pulmonary hypertension. You can think of, for example, conditions such as bronchopulmonary dysplasia or acute pulmonary hypertension of the newborn due to peritoneal pulmonary vascular maladaptation. So what are these thresholds that we can use to define pulmonary hypertension? So after 3 months, most newborns should have reached their normal state of pulmonary vascular resistance. And usually we adopt the values that have been established for the pediatric and adult population, which are if you have a mean pulmonary arterial pressure equal or above to 20 millimeters of mercury, that is considered to be high in terms of having a high pulmonary pressure in your pulmonary artery. Now, by echo, you can definitely try to estimate the diastolic and mean pulmonary arterial pressure using the pulmonary insufficiency jet, but this is not often present on echo. And so the most common marker by echo that we use to estimate pulmonary pressure is the systolic pulmonary arterial pressure by either tricuspid regurgitant jet, or if you have a VSD or a PDA, that might give you an insight on the flow direction and estimates of systemic pulmonary blood pressure in terms of the systolic values. And so typically we highly suspect the presence of high pulmonary pressures after 3 months of age if the systolic pulmonary arterial pressure is estimated to be equal or above 40 millimeters of mercury. Now, we know that in the first 3 months, there's a rapid and progressive decline of the pulmonary vascular resistance. As you remember, during fetal life, the lungs are usually in a state that are filled with amniotic fluid, and the pulmonary vascular resistance are very high. And after birth, there's multiple triggers and mechanisms by which, first of all, you get pulmonary expansion and mechanical stretching of these pulmonary vessels that are lining the alveoli. But as well, you get a trigger of cascade of molecular changes that are leading to pulmonary vascular vasodilatation. So you can think of, exposure to oxygen, the increased production of endogenous nitric oxide, and shifts within calcium influx inside the smooth muscle cells of the pulmonary vascular bed that are all going to lead to this very rapid expansion of the pulmonary vascular network. And this will lead in a drop in pulmonary vascular pressures. And so in the first 3 months, we often will look at the pulmonary pressure and we'll compare it to the systemic pressure. And most experts will tell you that, at least I think most people will agree that it should be less than systemic. And as you go along this pathway of the first few weeks of life, the pressure should definitely drop well below systemic. And usually by 3 months of age, you should reach values around 15 of systolic, 5 of diastolic, a mean of around 10. So how do we estimate pulmonary arterial pressure by echo? So one of the most common markers that are used is what we call the tricuspid regurgitant jet velocity. So this is an apical 4-chamber view. You can see a right ventricle, a right atrium, and you can see a tricuspid valve. And during systole, while the right ventricle is contracting and the blood is ejecting in the outflow tract, the tricuspid valve is closed. And so if there is some incompetency of the valves, you can get blood returning from the high pressure chamber of the right ventricle to the right atrium, and this will create a velocity of flow. So as afterload of the right ventricle starts rising, usually you can see some degree of right ventricular dilatation, and this tricuspid annulus might start dilating also, and the coaptation of the valve may become less competent. So it's not uncommon to see that a patient will not have any tricuspid regurgitant jet, especially if the valve is well competent. But many patients with pulmonary hypertension will end up with some degree of annular dilatation, and eventually you'll see this tricuspid regurgitation appear. And as the RV dilates even more and the tricuspid valve dilates even more, sadly our estimates become less accurate because the whole principle by which we measure these velocities assume that the true opening is a narrow point. The other thing is that, to generate velocity, you need to have a pump that works. And if your right ventricle is failing to a point that it has difficulty generating any kind of velocity, you may have very low pulmonary arterial pressure, but that's because you have very low flow in the pulmonary artery, and that does not necessarily reflect the underlying distal pulmonary vascular resistances. So to generate pressure, you need to have a pump that works. But as the patient is having progressively failure of the right ventricle, you might lose some of the appropriate correlate between pulmonary pressures and the degree of pulmonary vascular resistance. So if you put what we call a continuous wave Doppler, which will measure the velocity along the entire line of integration of your ultrasound probe, you'll measure the speed by which this flow is happening between the right ventricle and the right atrium. And so by measuring this speed at the peak of systole, you'll have a sense of what is the RV pressure at the peak of systole. Now, there is a simplified Bernoulli equation that tells you that the pressure difference between the two cavities, it's 4 times the velocity to the square, and gives you a pressure gradient in millimeters of mercury. And this is only true if the opening of the jet is a narrow point. Now, if there is no obstruction between the RV and the PA, you can assume that there's a pressure equalization in systole between the RV and the PA. And as such, your TR jet, RV-RA gradient, will be a reflection of what's happening in the pulmonary artery. Now, we have to assume a certain degree of right atrial pressure, knowing that the TR jet represents a gradient between the RV and the RA cavity. Now, if you assume that the pressure in the right atrium fluctuates between 0 and 5 millimeters of mercury, we typically use 5, and we add it to what's our RV-RA gradient to have an estimate of systolic pulmonary arterial pressure. You have to be aware that as the right ventricle will start failing, you might get some degree of RV diastolic dysfunction, and because of that, you might have some increased RV and diastolic pressures. And when you open your tricuspid valve and equalize your pressure between your RV and your RA pressure may be, way over the estimate of 5 millimeters of mercury. And in babies in particular, it's difficult to have, an estimate of RA pressure, and unless you have a central venous catheter to measure your RA pressure, using measurements such as, the IVC caliber, or, using the sniff test for IVC, collapse and get an appreciation of RA pressure. It's not really validated in babies, and it's very hard to ask a baby to do a sniff. So usually we use about 5 millimeters of mercury. So if you take in that particular example a velocity of 5.45 and you put in the Bernoulli equation, it gives you a RV-RA of 119 millimeters of mercury, and we assume here that the RA pressure is about 5, which gives you an estimate of 124 millimeters of mercury of systolic pulmonary arterial pressure. That's assuming that you don't have a pulmonary stenosis, a pulmonary embolus that's blocking at the outflow tract. And, if you can think of a patient who has a very large unrestricted VSD, you're basically going to measure what also the LV systolic pressure is generating, because your RV and your LV will be equalizing their pressure in systole. So you have to put all of this into context when you're trying to estimate pulmonary pressure, and remember that you're not estimating pulmonary vascular resistances, but really having a sense of pulmonary pressures. The next marker, I kind of alluded to this marker at the beginning of the presentation, is pulmonary insufficiency jet velocity. It's a similar concept as the tricuspid regurgitant jet, except that the pulmonary valve will close during diastole. So the Doppler profile gives you a sense of what's happening in the diastolic phase of the cardiac cycle. So similarly to the TR jet, if the RV and the main pulmonary artery starts dilating, the pulmonary valve annulus will start to dilate. The valve becomes less competent. You might see appearing some pulmonary insufficiency. And typically, you'll see that during parasternal short or long axis in a sweep that's quite anterior to capture the RV outflow tract. Or you can also obtain it from an RV focused view in the apical chamber, where you can go interiorly and try to see by color if you get some red flashes indicating that you have some pulmonary insufficiency. And so the early insufficiency jet will give you an estimate of the mean pulmonary artery pressure, and the end diastolic jet will give you a sense of diastolic pulmonary arterial pressure. And usually it's also a gradient, and you have to assume that in diastole, your RV pressure is kind of similar to the estimated RA pressure, since in diastole the tricuspid valve is open, and your RA and RV will have pressure equalization. So we usually use about 0 to 5 millimeters of mercury. So in this patient in particular, if you see that you have end diastolic PA pressure, or end diastolic, I should say, PA-RV gradient of 34 millimeters of mercury, well, you already know that you're way beyond your estimated 20 millimeters of mercury. If this patient is more than 3 months of age, that would definitely fit into a category of pulmonary hypertension. You can use also some of the shunts to assess some of the degree of systemic to pulmonary relationship. So, for example, a ventricular septal deflect will give you a sense of what's happening between the LV and the RV. If it's unrestrictive, well, basically you're gonna pressure equalize the two chamber, and your RV will be subjected to the LV systemic pressures. And that particular patient may have, high PA pressure secondary to that, but, it might be in a situation where you get overflow circulation and you get too much blood flow going to your pulmonary vessels. So it doesn't tell you that your pulmonary vascular resistance are high. But if it's very unrestrictive, you can also use the Bernoulli equation to have a sense of what's your RV pressure in systole. So remember that your VSD is a lesion that will cause often over-circulation and increased pressure on the RV compartment during systolic phase. The PDA exposes the pulmonary circulation to both the systolic and the diastolic phase of the cardiac cycle to systemic pressure and systemic flow. So often if it's large and unrestrictive, similarly, it will expose the pulmonary circulation to systemic pressures in systole and diastole, as well as overflow circulation. But if it's restrictive, depending on the direction, first of all, you can have a sense of the PA pressure. So for example, if it's bidirectional, typically you should have around isosystemic PA pressure. If it's right to left, it's suprasystemic PA pressure. So right to left, I mean the pulmonary pressure is shunting to the systemic compartment. Now, maybe the systemic compartment has very low pressure, so you can think of a patient who has a coarctation or interrupted aortic arch, where your systemic pressure in the descending aorta might be very, very low, and your PA pressure might be within adequate limit, but might be shunting right to left to provide flow to the descending aorta. So, when you talk about having isosystemic or suprasystemic, you always have to be cognizant of what's happening on your systemic compartment. Now, if the PDA, although it's a tubular structure, so you have to be careful when applying the Bernoulli equation, whenever it's restrictive, you can assume that the end of the funnel is a pinpoint area, and you can also try to apply some of the concept of the Bernoulli equation. So very low velocity PDA will generally be associated with similar pressure on both sides. So that's an example of apical VSD that is quite restrictive, and you can see that there is a gradient of 20 millimeters of mercury. This patient has a left to right muscular VSD, and as such the LV pressure is higher than the RV pressure, and at the peak of systole, you know that the LV pressure is 20 millimeters of mercury above the RV pressure. And so you can assume that if, for example, you have a systolic blood pressure of 80 millimeters of mercury, your PA pressure is at least, at maximum around 60 millimeters of mercury on the systolic compartment side. Similarly, on the upper panel, you can see a very large unrestrictive ductus that is left to right. We have the pulmonary artery on top and the descending aorta on the bottom, and you have kind of these three little legs, and the red one is the left to right shunting via the ductus. And the Doppler profile shows that there's very rapid equalization of an unrestrictive duct. So although the PA pressure is slightly below the aortic pressure, there's rapid pressure transmission to the pulmonary compartment. On the bottom side, you can see that actually it's a very low velocity on a restrictive PDA, so it tells you that the PA and systemic pressures are kind of a similar range. On this panel, we see a bidirectional shunt by putting CW Doppler through this. You can see that on the left side, you have bidirectional with a gradient of 30 and systole is right to left. So there's a portion of cardiac cycle where the PA pressure are quite significantly suprasystemic, versus on the right side, you can see that the gradient is only 3. So really, we're talking here of isosystemic pressure in that particular patient. This example is another patient who has blue jet, so tells you that the shunt is right to left from pulmonary artery to descending aorta. And here, when you put a CW Doppler, you can see that the gradient is at the peak of systole of 46 millimeters of mercury, which tells you that there's suprasystemic PA pressure with a systolic peak of 46 above the systolic blood pressure. Now, it might be that the descending aortic pressure is very low, or it might be that the PA pressure is very high, or it might be a mix of both. We can also use the Doppler from the pulse wave Doppler obtained at the tip of the pulmonary valve, usually in the parasternal short axis, but could also be obtained in the parasternal long axis with anterior sweep or apical four-chamber view with RV focused view. And typically the pulse wave Doppler indicates along the x-axis the time, and on the y-axis it's the velocity. So usually there is a parabolic shape of the pulse wave Doppler of the main pulmonary artery at the RV outflow tract at the tip of the pulmonary valve. And this parabolic smooth acceleration and deceleration shows that there's relatively low RV afterload. Now, with increasing afterload, you can notice some shorter acceleration and more of this triangular shape, like in the figure B. And as the afterload increases, there can even be a mid-systolic notch with significant, for example, high increased pulmonary vascular resistances. This is due to the recoil of the pulmonary arterial wall that has dilated. And usually we can do a ratio called the pulmonary artery acceleration time divided by the right ventricular ejection time. And if it's less than 0.3, it is suggestive of increased right ventricular afterload. So this is an example in parasternal short axis where the acceleration time is 85 millisecond and the ejection time, which is the entire Doppler envelope, is 224 millisecond and has this parabolic type of shape. Versus if you look on the right-hand side in a patient with high pulmonary hypertension, you can see that there's more of this triangular type of shape. So when looking at the Doppler, we usually position it at the level of the tip of the pulmonary valve, and then sometimes in some of increased afterload, you can even notice this mid-systolic notch. So these are indicators that there might be underlying increased RV afterload. We often want to assess also the right ventricular to left ventricular crosstalk. As you know, in normal cardiac configuration, the right ventricle is usually crescentic when we are looking at a cross-sectional view. So this is a parasternal short axis view, and we can see that the left ventricle has this round shape at the mid-papillary muscle level, and you can see on top anteriorly this right ventricle, which is kind of hugging the LV. So remember that the right and left ventricle are sharing this interventricular septum, and the shape of the ventricles are obviously quite different in their geometry and configuration and the way they're functioning. And it is expected that the pulmonary pressures are being lower than the systemic pressures, that you will find that the right ventricle has this crescentic shape, kind of hugging the left ventricle from on top. So at the peak of systole, the pulmonary valve is open, the aortic valve is open, and the RV will equalize with the PA pressure, and the LV will equalize with the aortic pressure. And if the pressure within the pulmonary artery is high, you may start seeing that there is some degree of flattening of this interventricular septum. And obviously, the RV-LV crosstalk gives you a sense of what's happening in relationship to both sides. So you always have to put this into context of what's happening on the systemic compartment. So usually when the LV is under higher pressure than the RV, and then there's at the end of systole, so during contraction, the LV is round and the RV is crescentic, surrounds the LV. Now, when the valves are open, when the valves are closed, the pulmonary and aortic valve, so during diastole of the ventricles, If you see flattening of the septum, it indicates that there's probably similar pressures on both sides at the end of diastole, and that probably that can be seen in situations such as high volume overload of the right ventricle, or in the context of diastolic hypertension of the right ventricle when there's RV failure. So here you can see that there's various degree of septal flattening, and as the RV afterload will increase, you get dilatation of the RV, and eventually you can even get this kind of pancaking of the LV where you get some impingement within the LV cavity. And typically we see this bowing septum in patients who have some degree of suprasystemic pulmonary pressures. So in order to quantify the septal deformation, you can use an index that's called the left ventricular end-systolic eccentricity index. Typically, we measure the diameter that's parallel to the septum, and we do the ratio to the diameter that is perpendicular to the septum. And ratio of less than 1.3 has been associated with relatively normal PA pressures. One can also do the measurements that is perpendicular to the septum but on the right ventricular side and do the ratio to the LV side. And typically the LV diameter perpendicular to the septum is bigger than the RV diameter perpendicular to the septum. So that ratio, the RV and LV ratio, could be a ratio to measure the degree of ventricular dilation on the right ventricular side. But this is, dependent on the fact that the LV has a relatively normal dimension. So this article that was published by Abraham and Wiseman looked at a population of patients with pulmonary hypertension and found that there was a high inter-observer agreement for eccentricity index, and described that there was some degree of septal flattening with an eccentricity index above 1.15, but that they could find actually anomalies of RV systolic function only when they had eccentricity index above 1.3. So when looking at the RV RV-LV crosstalk, one might want to also look at the interatrial septum because it will give you some information if you have a normal cardiac configuration of what's happening at the level of the end of diastole. So for example, here on the left or right, PFO shunt, where the blood flow is going from the left to the right atrium, usually shows that there's a slightly higher and diastolic pressure on the left atrial side. If it's bidirectional, you expect some isosystemic pressure on both sides, and if it's right to left, it's usually in situations where you have increase in diastolic pressure on the right-hand side. So if you have, for example, RV failure, your right atrium has difficulty emptying in the right ventricle, the pressure within the right atrium will build up and eventually will unload into the left atrium, bringing deoxygenated blood into the systemic circulation. Other signs of RV diastolic hypertension could be things such as dilatation of the inferior vena cava or superior vena cava, but those are typically a bit more subjective measurements, or if there's a significant amount of retrograde flow in the IVC or SVC. So whenever you're talking about pulmonary hypertension, the end result is often some degree of RV dysfunction. So it's important to understand how to quantify RV function when assessing these patients. So we know that cardiac function is very dependent on the architecture of each ventricle. It's dependent on the crosstalk between these ventricles, but also on the precise activation by the conducting system. So you can imagine that if you have anomalies of activation or if you have some fibrosis, so in terms of dispersion of the electricity, that might have an impact on how the myocardial structure will contract. And so if you look at the right ventricle, it has a really specific geometry. It has fibrous discontinuity between the inflow valve and the outflow valve. It has this peristaltic motion that brings the inflow, so typically tricuspid valve, towards the right ventricular outflow tract, which is usually the pulmonary valve. And you have this interventricular septum that bulges towards the RV cavity, which This might be impaired in the context of significant RV afterload, where you get dyskinesis of the septum. And you get this free wall that's usually going towards the interventricular septum. And so typically the right ventricle will have mostly a longitudinal type of contraction. So you can see here that there's an apical four-chamber view of the RV and the RA, and you can see this tricuspid valve kind of jumping up and down, plunging inside the RV cavity during systole as the right ventricle is contracting. So one of the most common measurement of right ventricular function is the use of what we call TAPSE, which is tricuspid annular plane systolic excursion, and measures this longitudinal movement as it plunges into the RV cavity. The fractional area change could be done in apical four-chamber or RV-focused apical three-chamber view, where in the four-chamber view, we look at the end-diastolic area minus the end-systolic area and the overall divided by end-diastolic area, usually with a measurement about 35% considered normal. If you're doing it on the RV four-chamber view, typically you see the lateral free wall and you see the septum. If you're doing the three-chamber view, you would see the posterior and anterior portion wall from the inflow to the outflow tract. And so normative value for both TAPSE and FAC have been published by gestational age. And so these are an example on the left-hand side of fractional area change. So you can see the tracing in diastole, and you can see kind of superimposed the tracing that was done on the end-systolic side, and you do a ratio EDA minus ESA, the whole divided by EDA, and you can have a value of FAC. And this value has correlated with right ventricular ejection fraction by MRI. The TAPSE is usually measured by M-mode, where you measure the distance of the hinge point of the tricuspid valve as it plunges towards the inside of the cavity. And so, as I mentioned, this is only one of the sets of the publications out there looking at gestational age and normative value for TAPSE in terms of mean and standard deviation. This is the RV FAC in three-chamber view from a publication in the Journal American Society of Echo by M.S. Jain and colleagues. And on the right-hand side panel is an actual echo of where you see an inflow-outflow tract view with the anterior and posterior wall of the right ventricle. Whenever you're looking at pulmonary hypertension, you want to have also an assessment of right ventricular dimension and pulmonary dimension. So this is the standard way of measuring the RV basal diameter, mid-cavity diameter, and longitudinal diameter as the RV can start dilating in the context of pulmonary hypertension. One might also want to measure the right and the left pulmonary artery as well as the main pulmonary artery. And as you can see, there's also standards for measuring the right atrium and to measure the planimetry of the right atrium that might dilate if there's diastolic dysfunction of the right ventricle. Now, obviously, if you have a pop-off ASD, your right atrium might not dilate as much as it would happen without an ASD. And so, when looking at RV afterload, you can look at some of these measurements, and there's normative value by Z-score for body surface area. You can find some of these calculators and links on the website in the normative value section. This is an example of a patient with significant pulmonary hypertension, RV dilation, and really depressed RV performance and function. There's a big RA on top of it, and there's probably both systolic, diastolic dysfunction, and the LV looks completely pancaked. You can also kind of appreciate some degree of pericardial effusion, and that's usually a finding that we see in some of these patients with severe pulmonary hypertension. When looking at performance, we can also assess systolic and diastolic function using tissue Doppler imaging, which assesses myocardial velocities during systole and diastole. It's typically you put your sampling envelope just below the tricuspid valve on the free wall of the right ventricle. They're highly angle dependent, and they may be influenced by tethering of myocardium. So if you have areas of myocardium that are poorly contractile, it won't necessarily detect it if the area that you're sampling is actually contracting adequately. It is heart rate and load dependent, like most measures we use by echo. And you can use it to calculate what we call the myocardial performance index, which is a measure of systolic and diastolic performance, and usually calculated as the isovolumetric contraction time plus the isovolumetric relaxation time divided by the LV ejection time. And normative value have been published. So in this panel, you can see that you can measure the systolic velocity, so the peak velocity of the myocardial movement in systole. And then you can often measure also the early and atrial phase of diastolic function. So the early phase is when the ventricle gets this early passive filling, and the A phase is during the atrial contraction, and the velocity of those can be associated with your diastolic performance. And so there's limited data of measuring diastolic function, but one can have some impression using the MPI, but also you can use the Eon A velocity of the tricuspid inflow Doppler by pulse wave, the Eon E prime by TDI, and you can also do diastolic strain rate, which I'll discuss a bit later. So this is an example of inflow velocities. You have, again, the early passive filling, which usually is the majority of the filling occurs during this phase. And then you have the atrial kick. Now, you must have to keep in mind that in the immediate postnatal life, newborns have faced significant pulmonary vascular resistance for a prolonged period of time during the entire gestation, and the RV is actually remodeling progressively after birth. So it's not uncommon to find a reverse pattern of Eon A velocity, but a bit later in life, so usually after a few months of life, we should expect to see E that is higher than A, and that's why the ratio is typically higher than 1. One can also use the E velocity obtained here, so the first peak, and divided by the velocity obtained by TDI on E prime as a marker of diastolic function, although normative value within pediatrics and newborn especially are yet to be confirmed and defined. Other indirect measurements are things such as right atrial enlargement, bidirectional right to left shunt at the level of the interatrial septum, and then you can also look at the subhepatic veins or IVC in terms of the flow. If there's a lot of retrograde flow, that could be a bit concerning for increased right atrial pressure. Many experts, especially in TN echo, advocate for the measurements of right ventricular estimated output. Typically, we measure the pulmonary valve or the RV outflow tract cross-sectional area in the parasternal short axis view or parasternal long axis view at the hinge of attachment of the valve, and when it's in open phase. And you can measure what we call velocity time integral, which is the estimated stroke distance, and use these elements to calculate or estimate cardiac output of the right ventricle. Now, it's a bit of a controversial measurement in the cardiology community, I would say, since it is prone to mistake because the RVOT to the square, if you do just a little mistake in your measurements, the measurements is squared. So obviously there's variations there. But if it's used consistently by one operator, typically it is valuable information for estimation of the performance of your ventricle, especially when you're following a patient in which you want to monitor the response to certain treatments. So that's an example of RV outflow tract where we can measure the pulmonary valve and then use it to calculate the cross-sectional area. And then if you put your cursor at the tip of the valve and do a pulse wave Doppler, you get estimation of a Doppler at that area of the probe. And you can measure the area under the curve. So I remind you that this curve on the x-axis is time and on the y-axis is velocity. So if you look at the area under the curve, you typically get a distance. And in this particular patient, you get a distance of 19.4 centimeter, indicating that your stroke distance at that point in time was 19.4 centimeter in that specific area. And so once put into the formula for calculating output, This is for your stroke volume, and stroke volume times heart rate gives you your output. So you got your RVOT, you got your RVOT VTI, and you can get an estimate of your stroke volume. And typically it's calculated and indexed based on the weight of the patient. And normative value has been described as above 150 cc per kilo per minute. So I want to spend a few minutes talking about strain. Strain is a physical property of any kind of matter per se. So speckles or echo densities or pixels compose the echo images, and you can track them on a frame-by-frame basis to measure the magnitude or percentage of deformation. And so this absolute percentage of deformation is what we call the strain measurements, and the rate at which it occurs is, or the speed at which it occurs is called a strain rate. And you can use that to measure segmental analysis or rate of myocardial expansion and diastole, for example. You can use it for rotation assessment of the LV. So here, this is an example of a right ventricle in which we have measured at the level of the endocardium both the RV fuel wall and the septum. And what you can see is that you track the pixel from the old to the new location, and you're able to assess how much of that length changed in time. And by convention, if the length increased, it's a positive value, and if the length decreased, it's a negative value. So in the context of contraction, you get a kind of decrease in the length of each segment, and so you're going to get a negative value. You can apply this technology to 3D volumes, so you acquire either single or multi-beat volume of a right ventricle per se, and then you can put this in models, and from the 3D images can obtain stroke volume and ejection fraction as well as dimensions. And there is more and more data coming out for 3D assessments in the neonatal population. And the last thing is, obviously, if you have high PA pressure, well, then you need to kind of do your detective and figure out what's the etiology. And don't forget to always look at the left ventricular side. So you want to make sure, for example, that your pulmonary venous drainage is within normal limit, that you don't have signs of pulmonary stenosis. You want to make sure that you don't have mitral stenosis or severe mitral regurgitation. You want to make sure that your LV size and LV performance is within adequate limit, that you don't have aortic stenosis. So always make sure that there's no obvious signs of post-capillary pulmonary hypertension. So thank you for listening to this module. This is just really an introduction for the basics of understanding the mechanics of pulmonary pressures and their estimate by echo. Echo is an imprecise technology to measure pulmonary pressures, but it gives a good sense in terms of screening. It's something that has no radiation, allows for live evaluation. You can follow your patients actually quite easily whenever you do interventions, and it may answer a lot of questions at the bedside. So hopefully this presentation was helpful. And before applying any of these concepts, I recommend that you go read the literature, review some of the Hallmark textbooks. And if you have any questions, my email is here. Thank you for your attention, and hope you enjoyed.